to ask the next question. Simon, you have the floor.
Thank you for taking my question. This is Simon Ateba for Today News Africa in Washington, D.C. Hospitals in Malawi are now on the brink of collapse, overwhelmed by patients impacted by a COVID-19 variant first identified in South Africa. And the country needs only 40,000 vaccine doses to help vaccinate healthcare workers to continue to treat others. And this is the situation in other countries in Africa, where healthcare workers need to be vaccinated first to take care of other people. What is the WHO, the COVAX, and others doing to ensure that healthcare workers are vaccinated right away, not in 2 weeks or in 3 weeks? And if I may ask, apart from rejoining the WHO, is President Biden doing anything to help Africa's vaccination effort? Thank you.
2 questions, Simon. Okay, Dr. Bruce Aylward will take your first question.
Yeah, thank you very much, Simon. Everybody is deeply concerned about the rollout of vaccines globally, and everyone, it's not just WHO, everyone we work with doing everything possible to scale up and ensure countries that have not yet been reached with products can be reached. So WHO is doing this in the context of the COVAX pillar of the ACT Accelerator that we work within, and Seth may want to make comments on this as well. But there's really a 4-part approach we're taking to this right now, and we're doing all of this right in parallel. The first is to try and ensure that those products that we've contracted large volumes for and that we know are efficacious and safe, they get through the regulatory processes as rapidly as possible. And that is the AstraZeneca vaccine, as Kate and others have spoken to already. The second thing we've been doing is working to expand the portfolio of vaccines, as Dr. Berkeley mentioned. So we're looking at other products that have already been licensed. The Pfizer vaccine, we struck a deal with Pfizer 2 weeks ago, and we're looking at expanding on that. The third piece of work that we've done within the COVAX facility, this has been done, is to establish the capacity to take donations and doses that are shared from countries that feel that they are in a position to be sharing doses. So we established the capacity to do that, which can be done immediately. And then the last thing that we're doing is we're working with to assess other potential suppliers. I think, Mariangela, someone referred already to the fact that we have a team on the ground in China that's assessing the facilities at Sinovac and Sinopharm. At the same time, we're looking at their dossiers, their data, to see if those products could be suitable for consideration in the facility. So we've got a broad, 4-pronged, at least, program of work. The other thing that we're doing is, as we do those things, in parallel, if things look very promising, we're going out with countries with indicative volumes of vaccines. As you saw, Dr. Berkeley's team from Gavi issued what we call the indicative volumes to be able to tell countries, here's how much vaccine you can expect in the coming months, so that they can prepare their timelines appropriately. And then linked to that, we are also already informing not just the countries, but informing the manufacturers of these products. Look, this is the list of countries that you may need to be shipping vaccines to within the next week, as some of these products will have a final position on their regulatory processes. So, Simon, please rest assured that everybody working in COVAX, the partners working with them, are doing everything possible to make sure that products arrive everywhere as rapidly as possible. But remember, we made a commitment when we established COVAX that we would make sure the vaccines that we deliver are safe, efficacious, and quality assured. We made that promise to the world, to the people of the world, and it takes time to examine everything possible on these vaccines and make sure that they meet what are quite stringent regulatory requirements, so that when they go out, people have the absolute confidence that these products are going to work and that they're going to be safe.
Thank you. Dr. Ryan?
Just on the specific issue of Malawi, and certainly South Africa had seen a very rapid rise in cases, and that rise that's falling now. And a number of countries in Southern African area, including Malawi, had seen a similar very rapid rise in the number of cases. I believe they peaked in Malawi with 1,316 confirmed cases on the 22nd of January. That number has now fallen to 320 on the 7th of February, and that's been a persistent fall in the number of cases. And again, that's testament to all the other work that the government of Malawi are doing in terms of testing and isolating and quarantine and treating cases. That's happened in the absence of vaccines. We've seen similar falls across Europe, even in areas where there's been high proportion of variant strains associated with transmission. Overall, when we look at variant strains, in some areas the data would suggest that they can be up to 30 or 50% more transmissible, but they're not able to get around our defences. When those measures are applied, those public health and social measures, when people wear their masks, when people stay away from crowds, when people wash their hands, when people avoid crowded places, and when governments take the necessary action, those numbers fall. We need to continue to have those numbers to fall, and clearly the understanding the impact of the variants on transmission and on vaccine efficacy and others is very important. But I think the message is the measures we currently have in our toolkit work, and we need to apply them. They're our first line of defence. They are what are going to stop this disease getting out of control. This will keep the number of variants down and allow the vaccines to come in and do their job. And the primary job of vaccines right now is to reduce hospitalizations and death. And right now, the data on, I think, all of the vaccines and all of the situations that they're working to do that. We may need second and third generation vaccines to do more. We may need better vaccines to do more than just stop deaths and stop hospitalizations. But right now we have the tools to stop both by adequate control of the disease at community level and by the use of vaccines to protect the most vulnerable and our frontline health workers. And in emergency management, you've got to do what you can do now. You've got to face the realities you face now. And the realities we face now is we can suppress transmission and we can save lives. If we do that, we can take the next step. And rest assured, the team here, Kate and Sumia and Anna Maria and the R&D Blueprint and Richard and everyone outside, they're working hard to find those solutions on the vaccine side and working hard with our colleagues in the flu programme to develop a system to monitor this and do this in a sustainable way. But I do think we need to focus on what we have at our disposal. No one would like more than us, and going back to previous questions, we still want to see health workers and vulnerable people all over the world vaccinated. That is still a primary objective of this organisation. And I think the partners in the ACT Accelerator, the partners in COVAX, led by the DG, are making every effort to ensure that we can maximise the fair and equitable distribution of this vaccine. That is saving lives and can save more lives.
Thank you. I think we will take a last question from Gabrielle Steinhauser, Wall Street Journal. Gabrielle, can you hear me?
Yes, I can. Thank you so much. Can you hear me?
Very well. Go ahead, please, Gabrielle.
Great. So given that it's going to take some time to get more evidence on how the AstraZeneca vaccine works with the South African variant, shouldn't COVAX maybe prioritize other vaccines, such as the Pfizer vaccine, for countries in Southern Africa where this same variant is dominant at the moment? Can't you shift some of these vaccines to those countries so that the frontline healthcare workers get the best protection that is available right now?
Thank you, Dr. Swaminathan. You have the floor.
So maybe I can start and then Dr. O'Brien can come in. Well, there are several issues here. The first one is I just want to repeat what Mike said. We mustn't start, concluding that this vaccine doesn't work at all. What we've seen is data from a small study. It's indicative. It is telling us we need to collect more data. We need to study it more. But from all the available evidence, the AZ vaccine and all the other vaccines that have been approved so far reduce death, reduce hospitalization, and reduce severe disease. And that's our goal for the first part of this pandemic, is to reduce mortality, to end all preventable deaths. And so we must continue to scale up vaccines. Now, about which vaccine, it depends on what's available in the COVAX facility at a particular time and also what's feasible. And as you know, the Pfizer vaccine has some special requirements, ultra-cold chain storage and transport, which is not available in all countries in Africa or in other parts of the world. So we've done an extensive mapping, and Kate can speak to how, this has been looked at the country level. So that's an important issue, but also it's the supplies. And the COVAX facility had made prior arrangements to get a lot of supplies of the AZ vaccine in millions of doses, whereas with Pfizer, we have a very limited supply, especially in the first part of the year. So there are all of these considerations. And the important thing is to get these vaccines out to healthcare workers and other high-risk groups as soon as possible. Do you want to add some points, Kate?
Yeah, I think the other thing to mention is that for pretty much all of the products, we do know that the efficacy against severe disease is a higher efficacy than against mild disease or just infection. We're starting to get some evidence around infection without people actually having disease. So we do expect this gradient, and I think especially for the AstraZeneca product, the sort of evidence, the absence of evidence is the kind of key thing about what is the performance of the vaccine against severe disease of this particular variant. And the expectation is that it will have, there's a very plausible scenario where it will have efficacy of some magnitude against that severe disease. So I think what we want to also emphasize here is the reason to have a portfolio of vaccines in the COVAX facility and that are being pursued from a development perspective is that different vaccines are going to have different performance characteristics. And when we get to a point of supply where we have that flexibility to be optimizing products where we now have information about how they can best be used, and I think this is what we're talking about the optimization. But the optimization isn't just about the product itself, it's about how you use it. And so we've referenced before the information that is now more and more clear that the longer the interval between the two doses of this product, the higher the efficacy is. So again, I think what we're trying to emphasize is that we have a number of choices that any individual program can make about how to make best use of what's available at a particular moment in time, extending intervals, using products in some age groups with preference over other age groups, where we're really targeting an age group or a particular group largely for the protection against severe disease, or another group that doesn't have such high risk of that, but we're more concerned about mild or moderate disease. So the choices that an individual country makes about how best to use the products that are at hand is going to be a rather organic process at this period of time, where we're still learning so much about each of the products, and the supply is increasing over time, and availability for any one particular geography has variability compared with another geography.
Thank you, Dr. O'Brien. I believe Mr. Richard Hatchett has something to add. You have the floor, sir.
Sure. No, I just wanted to build on the comments that Dr. Swaminathan and Dr. Ryan and Dr. O'Brien made with respect to the utility of the vaccines that we have. Obviously, there is a world full of the wild-type virus that the AstraZeneca vaccine is known to work against. So it is vastly too early to be dismissing this vaccine as this is a very important part of the global response to the current pandemic, and we need to find better vaccines probably against the variants that are emerging, but that we still have a lot of information that we need to gather. Mike made a very important point that I think is worth underscoring. It's absolutely crucial to use the tools that we have as effectively as we possibly can. And that may mean ultimately when vaccine supplies increase, thinking about deploying certain vaccines to certain geographies. We don't have that luxury yet. But we do have a suite of vaccine tools that we can probe and understand how to use them most effectively in the current state. We are working rapidly. Many of the companies are working rapidly, as I said, to develop new vaccines that are specific for the emerging strains. And we are also looking at second-generation vaccines that have different attributes and that may provide broader protection. And ultimately, ideally, we would like to develop broadly protective COVID and even coronavirus vaccines. So there is a staged approach to the necessary research and development, but it is absolutely critical to continue to support that research and development so that we understand the tools that we have, we optimize them, and we develop the new tools that we will need for the future. Thank you.
Thank you, sir. I would like now to invite Dr. Tedros for his final comments. Over to you, Dr. Tedros.
Thank you, Fadila. I would like to start by thanking our guests today, Professor Abdul Karim, Dr. Berkeley, and Dr. Hachette. Thank you so much for joining and for your partnership. And also thank you to all who have joined today, to the media community, and look forward to seeing you again in our upcoming or next presser. Thank you. All the best.
Thank you, Dr. Tedros. I remind journalists that we will be sending the audio file and Dr. Tedros' remark right after the press conference. The full transcript of this press conference will be posted tomorrow on the WHO website. The press briefing is now closed. Thank you.